Hi, everyone. Thanks for coming. I'm Graham. I'm from the Center on Media, Crime, and Justice. Before we get started, I just want to let you know how you can participate, and then Caddy is going to introduce everyone. If you look the right-hand corner of your screen, you'll see there's a little chat bar, and I'm available on it. You should be able to see my name on that, and you can chat questions to me if you have any questions. You can also email me at graham@thecrimereport.org with questions. That's GRAHAM at thecrimereport.org. And otherwise, enjoy the webinar, and it will be available on the CMCJ network by tonight for you to use as a reference later on. And now here is Caddy Gray.
Hi, fellows. Thank you so much for all your great work. Just quickly, I'm going to introduce you to today's experts. You will remember Steve Rosenberg from the conference. He is president of Community-Oriented Correctional Health Services. The second expert is attorney Dan Mistick, who is general counsel for Steve's agency. And the other speaker is social worker Nina Marshall. She is public policy director at the National Council for Behavioral Health. And they will take it away right now. Thanks, you guys.
Great. Thanks, Caddy, and welcome, everyone. If you remember when we were in New York, we talked briefly about the Excellence Act and the intersection between criminal justice and mental health and how this federal initiative could change how things are working in your local community. Well, Wednesday is the deadline for states to apply for the Excellence Act. So I thought this would be a great opportunity to both refresh your memories about what the Excellence Act says and for us to be able to help you frame local stories, given that you have a lead coming up on Wednesday. And with that, Nina, why don't I turn it over to you?
Sure. So I'm going to pull up, Steve, if you want to talk through some of these slides on the intersection of mental illness and criminal justice.
Sure.
I'm going to share my screen. There it goes. All right, go for it, Steve.
Great. So as we talked in New York, obviously those folks who are justice involved have much, much higher rates of mental illness than does the regular population. You have a bar graph in front of you that shows male and female. Next slide, Nina. Substance abuse dependence, look at that difference, male and female. That's both actually male and female. And so remember, we talked about how there are all these programs going on locally: pretrial diversion, alternative sentencing, specialty courts, drug courts, mental courts. These are all things that we use to try to meet the needs of the behavioral health folks. But the challenge has been there haven't been adequate provider networks, and payment of service has been inconsistent. That's where the Excellence Act comes in, Nina. Great.
So hi, everyone. My name is Nina Marshall. I'm with the National Council for Behavioral Health, and we're strong supporters of the Excellence in Mental Health Act. And what the Excellence in Mental Health Act does is infuse $1.1 billion into states' behavioral health systems through certified community behavioral health clinics. It says $900 million on your screen, but that's a typo. It's actually $1.1 billion over 10 years. And it is a fundamentally Medicaid program and about expanding access to services for primarily Medicaid beneficiaries, but the clinics that will be become enacted as part of this legislation, the certified community behavioral health clinics, they will have a requirement of being able to serve people regardless of their ability to pay and regardless of their insurance status. So it's Medicaid funding, but people who don't have Medicaid will also be served by those clinics. It's expanding a range of mental health and addiction treatment services, including 24-hour crisis psychiatric care, and there are requirements around care coordination within the behavioral health system as well as among other pieces of the healthcare and social safety net. So there are requirements around partnerships with primary care, with acute care hospitals, with detox, with the Veterans Administration and other services as well. And there was strong support for the Excellence in Mental Health Act by some of the organizations that are included here. Very strong support from the criminal justice arena and public safety. The legislation created a demonstration program. So the first phase is that in May, SAMHSA, the Substance Abuse, Mental Health, and Substance Administration, released guidance for states on how to apply for a planning grant. Those planning grant applications are due on Wednesday. At this stage, we believe there are 27 states that are applying for those planning grant applications, and they will each have up to $2 million in awards. And the planning phase is actually a year long. It's October to October. But the planning phase is also actually a doing phase as well, because not only is it around figuring out how CCBHCs fit into the existing behavioral health system, it is also for states to actually go about the business of certifying those clinics, determining what rates they're going to be paid, and helping those clinics rise to the level and standards necessary to be providing the array of services required of CCBHCs. Then after the state planning phase, at the end of which states will apply to become one of the demonstration states, at this point in statute there is authorization for 8 states to be selected as part of a 2-year demonstration program. So in January of 2017 is when we expect that the announcement will be made about what 8 states are selected, and then it's a 2-year demonstration program from that. So this is a diagram of the required services for CCBHCs, Certified Community Behavioral Health Clinics. There is the items that are highlighted in green are services that have to be provided directly by the entity that's certified as the CCBHC. So you have to provide 24-hour crisis services, including mobile crisis, screening, assessment, and diagnosis services, patient-centered treatment planning, outpatient mental health and substance abuse services. And then there are other services listed here: psychiatric rehab, peer support, targeted case management, primary health care screening and monitoring, and then generally services for the armed forces and veteran services. The whole array that you see on the screen are services that have to be assured by the CCBHC, but they can do so through partnerships with other organizations. And one kind of partnership is a designated collaborating organization. So it essentially sets it up so that there is a core agency that is responsible for the total quality of the services that are delivered, for the management of those services being delivered, and all the financing flows through that clinic. But for organizations that don't fully provide all of these services themselves, they can round them out through formal partnerships with other organizations. Besides those formal partnerships for those 9 services we just showed you, there are also care coordination partnerships that have to be in place with federally qualified health centers, which are the primary care safety net organizations, rural health clinics, very similar to FQHCs but a different federal designation. They also have to have partnerships with inpatient psych and detox and residential programs. And then outside of the health sphere, there also has to be formal partnerships with schools, child welfare, housing agencies, and then also with the Veterans Administration and inpatient and acute care hospitals. The services, as I mentioned at the beginning, have to be provided regardless of the patient's ability to pay, and that there has to be a sliding scale. So you know, it's something where the CCBHC, there will be no wrong door. Anybody can come into the CCBHC to get behavioral health services, including 24-hour crisis management services. So Dan, I'm going to turn it over to you to talk about the sequential intercept model and how we can think about this differently if we actually have resources in the behavioral health system.
Great, thank you so much, Nina, and thanks everybody for being part of talking about this National Council, the Excellence Act, and how the criminal justice system is going to be changed by all of the resources now available. My name is Dan Bisbeck. I'm General Counsel for community-oriented correctional health services. And what I want to give you today is just a tool that will help you frame anything that you're going to be talking about or thinking about in the upcoming days and weeks as you're discussing the criminal justice system and also seeing how it fits in with the behavioral health system. And so one of the ways one of the useful tools in this process comes from SAMHSA's GAIN Center. This is called the Sequential Intercept Model. And what this does is it looks at different places along the criminal justice continuum and helps separate out into separate parts what is going on in each of these stages as somebody's moving through the criminal justice system, and also looks at the resources that are available to divert that person away from an incarceration stay. And so what we really think is going to be helpful is that we can see the ways in which the CCBHCs that are created by the Excellence Act are going to be able to really interact at each of these different points in order to be able to take somebody out of the criminal justice system and be able to put them into the community behavioral health treatment system. So the 5 different intercepts, I should also note that there are sequential intercept models for many of different large cities across the country. Last summer, when we were working with the Mayor's Task Force in Behavioral Health in the Criminal Justice System in New York City, the first thing that happened there was a mapping of what are the things that we have at each of these intercept points. Now, New York City, because it's New York City, decided to change the names of some of these things along the way. But there is still a map of New York City. There are maps of lots of different cities all across the country. So the first intercept in this is going to be law enforcement. It's going to ask the questions of what are the processes in place for, say, when a 911 call happens? What if this individual is having a mental health crisis? What are the local law enforcement's training, staffing? What are all of the different things that are available along the way while somebody is being pre-arrest, essentially? After someone is arrested, the second intercept point, that's going to be the initial detention and initial court hearing phase. And so this asks the questions of what are the things that happen, or what are the processes in place, or what are the resources available so that somebody doesn't, say, enter into a detention stay but can be released on his own recognizance. And also, while somebody is arraigned in court, what are the resources available so that somebody doesn't eventually get booked into jail or taken to jail? Which brings us to our third intercept point, which is going to be jails and court systems. So while someone's in jail, what are the treatment options? What are the ways in which people's healthcare needs are met in there? Or else also, what are the different kinds of secondary courts, like a mental health court or a behavioral health court, that can then be given to these individuals who are arrested, so that they aren't actually put into the typical criminal justice system, but are allowed to seek some sort of treatment. After a court disposition, then somebody is sentenced or given probation, or they are moved into a different phase of the criminal justice system, and that brings us to intercept 4, which is the re-entry phase. That includes also what are the services that reach in from the community to the jail in order to try and help these folks. Have a smooth transition back into the community again. Or the other option, of course, is they could be sentenced to prison, which has a completely different set of re-entry protocols. Once folks are removed from jail or able to leave prison, they go into the 5th intercept, which is community corrections. These ask the questions of what are the types of parole standards that an individual has to meet in order to remain out of prison, or what are the different standards that people have to live by while they're under community supervision for probation. And this is where a lot of the resources, again from the CCBHC, are going to overlap with what we see inside of the community and in the correctional field. So this can be another way of framing where and when these community the CCBHCs are going to be interlocking with the criminal justice system.
So Dan and Ms. Rosenberg, I have a question for both of you. So what you're saying that if a state chooses to participate and become a CCBHC in their state, that they're going to get resources that could keep folks and change their course in the criminal justice system at every one of these steps?
Yeah, that's right. I mean, I think that it's going to, the CCBHC is absolutely going to affect every single one of these intercept points all along the way, because now people are going to be having the resources necessary to get folks into, say, community treatment, community substance use treatment, instead of taking them to jail, which has been the default for way too long.
Oh, okay,
And
great.
let me add to that not only is it that CCBHCs are required to provide the full array of services that I was talking about and the way in which they can intercept at each of the points that Dan was talking about, but part of the infusion of this legislation, part of the legislation is infusing additional dollars into community behavioral health services. Outpatient behavioral health services are chronically underfunded, and so organizations often end up being forced to, take shortcuts, cut staff, not have the most up-to-date equipment for electronic health records or for telehealth services. And part of this legislation is it's setting things up so that behavioral health clinics are paid for the actual cost of their services, not just based on a fee schedule that doesn't align with actual cost. So by giving the clinics additional resources to actually provide the services, they're going to be able to provide a much fuller array and higher quality services.
So Nina, the fellows are all local reporters. Did I hear you say that if folks don't apply by Wednesday, they won't be able to participate in this program?
That's correct. Let me show you guys a map. This is a map that we have this was current as of Wednesday. There have actually already been some additional shifting in terms of red and green, but there are currently about 27 states that National Council believes are applying to be for the planning grant funds. The changes from what we're showing here on this is that Arizona and Wyoming are red, and North Carolina, surprising to all of us, is now green. But all in all, it's about 27 states at this point that are planning to apply for the planning grant funds, and those applications are due on Wednesday. And only states that receive planning grant funds are eligible to participate in the demonstration program. So only those that apply by Wednesday are going to be able to have any hope of participating long term.
So really a great local angle for the fellows. Patty, do you want to open up for questions?
Yeah, I actually have a question myself. The red states, why are they, and I'm looking at Arkansas because it was an early adopter of the Medicaid expansion. So the red states, why are they not opting into this planning at this juncture?
Well, so the reasons vary. Some states just did not pursue it for political reasons. There has been some misunderstanding, thinking that there is alignment between the Excellence in Mental Health Act and the Affordable Care Act. That's something actually that was a narrative happening in Kansas, where they kept saying, no, we can't take Affordable Care Act dollars when this has nothing to do with that. So for political reasons, that's part of it. Also, it was honestly, a really big stretch for states to be able to pull together the application in the time frame that they had available. So, the planning grant application came out at the end of May. They essentially had, I think, about 10 weeks to develop the application, but as part of that, there had to be a lot of strategic decisions made, including, what kinds of evidence-based practices would be required, how are they going to do the payment. You had to have all three health agencies in the state on board. You had to have the mental health, substance abuse, and Medicaid programs all in alignment about pursuing the application. So, there was a lot of just time pressure for getting this together. But then there are also political reasons, and there are also, just competing priorities for states.
So is this model, this template based on an existing model of service in any way? I mean, how did they come to, what needs to be in this construct?
So the idea of CCBHCs is largely modeled off of the primary care safety net equivalent of federally qualified health centers. That you have safety net organizations that serve primarily Medicaid populations that have pretty chronic health conditions, but because of the population they're serving and the underinvestment for the most part in Medicaid programs, the payment structure that federally qualified health centers have in place allows them to provide higher quality services. Also, federally qualified health centers also have some commonality nationally. So if you say that you're an FQHC and you're in Missouri, you pretty much provide the same array of services as FQHC that's in, Texas or New York or Oregon. So there's some commonality across that. There's also common quality and outcome measures that they're reporting. And so certified community behavioral health clinics is basically the same idea, that you have a common array of services that's required to be provided. So if you're a CCBHC in Texas and Missouri and New York and Oregon, you're pretty much providing the same array of services. While there will be some differential about how exactly they're structured and which exact evidence-based practices are provided, that there will be some variation there, but some commonality across the country. Those CCBHCs will also be reporting on the same quality and process measures, and so we'll have a better understanding from a national level about behavioral health service delivery. It's really a challenge at this point to be able to describe the services being provided. And like FQHCs, they'll be paid on the prospective payment system, which essentially is getting at providing the underlying cost of services for those providers.
Patty Rosenberg, I would answer that question similarly but slightly differently. I think what I would say is, under our federalist system, the federal government defines the rules of the road, and we leave it to localities to do the rest. So what I think happened here was the feds went and looked at what the best practices are likely to be to provide mental health services at a local level, define the rules of the road for that through the CCBHC requirements. I think that's what I'm hearing Nina say about how you're going to have parallels in different states, but they're leaving it up to the states to determine how that's going to play out locally. And that's why I would suggest you had some states that decided not to do it because they weren't ready to make that reach in a timely fashion before Wednesday. And there are other states that said the benefit of this is too great. We can't not get it together to apply to be one of these planning grants and hopefully one of the 8 states.
So are there localities that the feds looked at, best practices to sort of develop this? And if there are, where are those places?
I wouldn't say there were localities per se. I would say SAMHSA, the Substance Abuse Mental Health Services Administration, has a long history of trying to figure out what best practices are. And so they didn't as much look at a specific geographic location as they culled from the experience of multiple jurisdictions to try to define what the rules of the road should look like. And that's really what you see in the CCBHC.
Where would there be a listing of these clinics? Of where they are, who has the clinics and who doesn't? Where would a reporter find that?
Nina?
Well, so a reporter can certainly ask me, National Counsel, about whether a state is actually applying to become part of it. And then once the demonstration programs are up and running, this is just conjecture, but I would assume that that is a list that SAMHSA would maintain. And also state Medicaid programs would also maintain. Just like for federally qualified health centers, you go to HRSA's website and you can find one in any part of the country. I would think SAMHSA would do something similarly.
Just a quick question from Jonathan Martin of the Seattle Times. He just wanted to know what the yellow states are on the map. Are they unknown?
Yes, yeah. So the white states we don't know anything about. And the yellow states, they were contemplating it, but we haven't heard what their final decision was.
Nina, if I'm a reporter from a local paper within a state that's green, and I wanted to do a piece on how this might impact the system of care in my local system, where could I find a list of potential CCBHCs within my state or my community? Does the National Council have that? Is that something I could get from you?
Yeah, so if you go to thenationalcouncil.org, there is a listing where you can find mental health and addiction treatment organizations in all parts of the country. All of our membership is on that list. We can also put you in touch with the local associations who know very well how the services are structured and would be able to put you in touch with some clinics that would likely be a CCBHC.
I have another question. So what would be, if there are differences in how someone who's not been justice involved gets mental health care and someone who does, I mean, what are they? And this sort of, how does reentry fit into this?
So if I'm understanding your question, Kathy, what really happens, what the Excellence Act changes, is the Excellence Act makes a wider array, both wider and deeper array of services that will be available in communities for people who are justice involved. So the CCBHC will treat everyone, whether they're justice involved or not. But again, if we go back to what we learned in New York, that so many of justice involved individuals are dealing with mental health issues. What this will allow is for a greater breadth and depth of community services that will catch people at one of the intercept points that Dan defined before, and hopefully minimize their exposure and involvement with the justice system and switch that dial over to their involvement with the mental health system.
So that goes to my next question. How do mental health courts play into this, the whole system of diversion, not just in terms of reentry, but who is never locked down, period? How does that work? The mental health courts, how do they work within this framework?
And then after that question is answered, we have another one from a reporter. So once that one's on, we'll jump to that the other question.
So what I would say, Kathy, is if you look to specialty courts in general, the challenge specialty courts have had of finding a sufficiently wide and deep provider network to go ahead and make their referrals to. So typically what limits the number of people that we take through our specialty courts isn't the number of people that have infractions that would enable them to be eligible for specialty court. It's the availability of caseload that's related to the availability of community resources. And what the Excellence Act will presumably change in these 8 states, or in the planning states in the beginning, will be creating a wider and deeper array of community resources that will allow for specialty court expansion. And Graham, I'll be short here.
Thanks. Nina, you can, if you want, you can turn off the slideshow unless there's more. That's great. So Yvette Cabrera from the Voice of OC wants to know, she said, regarding the requirement that participating providers establish and maintain relationships with juvenile and criminal justice agencies, are there more details as to how this will work? I'm interested particularly with what will happen to juveniles who are in detention. Will they be diverted from juvenile hall, or will they receive more services while in detention?
So Nina, why don't you go to the requirements, then I'll try to answer that question in terms of juvenile.
The requirements are that you have a care coordination relationship, and that is still to be fleshed out at the state level. Part of what happens over this next year is that states take the federal guidance, the roadmap, so to speak, that was issued by SAMHSA, and then they will further define exactly what those relationships need to look like. But the fundamental principle underlying it is that the detention centers and mental health courts and all the folks who are intersecting with public safety will have somewhere that they can send people to get additional services.
Right, which is sort of exactly what I was going to say. It's not dissimilar from the answer I gave Katty about specialty courts, that right now the limitation is that there aren't very many community places that they can send juveniles who are involved in the criminal justice system. If the juvenile has Medicaid, Medicaid is a very low payer. Typically, their Medicaid caseloads are full for many agencies. Once Medicaid becomes a robust player, you'll have more breadth and depth and presumably able to do much more diversion.
So we have one more, actually. Another one just came in. This is Edith Brady-Lunny from the Pantograph in Bloomington, Illinois. She asked, is the plan to establish new clinics in communities or enhance resources for existing mental health centers?
Yeah, I would say both. What would you say, Nina?
Well, it has to, so technically for the demonstration program, they have to be clinics that were established prior to the enactment of the legislation. So they had to have been in place by by March 31st, 2014. But I fully expect that because of how comprehensive the services have to be, no, there are very few clinics that walked into this meeting that level of criteria and having that array of services. So what we're going to see happen in communities is a lot more aligning of different parts of the behavioral health system so that they come together.
Over to you, Patty.
Yeah, I have another question. So the 8 states, y'all have a hint of who those 8 states are likely to be, and though there are 8 demonstration states, rather, there are other states that will be building this network during the demonstration period, correct?
That's right, Patty. So let me try and take the second part first. As of right now, there are 8 states. As of right now, there are 8 states under the statutory authorization. I think there's a political question on the table. If 27 states are going to apply and put forth this kind of effort, given the joint movements to end mass incarceration and the experiences we've seen recently on people with mental health challenges that for lack of community resources have created all sorts of public safety issues. I think the question is, will Congress then choose to expand this beyond the 8 states? That's an unknown, but I think one of the very important questions that journalists may want to look at is what happens if they're not one of the 8 states and they've gone through all this effort to build this system and there are no additional federal resources. Where does that leave their local community? It's easy to do stories on how challenging it is right now for people to receive access to care and services. And so if you have a state that's gone through this planning process, I think that's a great question, and ultimately we'll have a political answer. And with Nina, I'll let you try to take the first question.
Well, let me add on to the second question first, which you know, currently the statute has a pot of funding of $25 million for the planning grants to be awarded. We have the grants themselves, SAMHSA said, could be up to $2 million, and there are about 27 states applying. So you can do the math here that if everybody applies for the full $2 million, there isn't going to be enough money in the planning grant pot to go around. So I think that's going to be something confronting folks at the federal level pretty quickly around what to do with these planning grant allocations if we only have a pot of $25 million. And then as for states that are likely to be demonstration states, I mean, there are a lot of really strong applications already in terms of states that have fought long and hard about the application, but you know, there are some states like Missouri and Michigan that have been doing it longer than others, that have been watching it much more closely and are hoping to make this a statewide initiative. So those are pretty well-positioned states.
Are there states who have currently specific programming for folks who were formerly incarcerated? Who's already doing that work?
I would say that slightly differently, Patty.
Okay.
I would say there are states that are trying to use their state dollars, or in some cases, grants from the Bureau of Justice Assistance, to develop reentry programs and pre-entry programs using typically a federal dollar through a grant program. I think if we look at state resources themselves, most of the state resources on meeting the needs of folks coming and going have been trying to enroll folks in expansion states in Medicaid expansion. I think what's really different about the Excellence Act is it is a federal and state partnership in which, while again the feds are going to define the rule of the roads and provide expanded resources, it's the states and the local CCBHCs that will be making the determination about how those resources are spent and how we use it to save the state and local dollar that's currently going to the cost of incarceration.
So those 5 points y'all had in the chart, in the slide, yeah. What's the difference in the reentry spot and the community correction spot? I'm Yeah, what's the difference?
Nina, can you get that back up on the screen so Dan can go through that?
Yep. 1 second.
So what reentry goes to essentially is what are the types of programs that actually reach inside the jail or reach inside the prison in order to try and ease the transition back out into the community. Community corrections, that covers more what are probation and parole doing to oversee the individual as they're going through their community supervision process. So what reentry is about. As you can see, the little arrows that come out of, say, jail / reentry and prison / reentry, those things don't necessarily always lead to probation and parole. Somebody could just simply be released into the community. There are going to be different types of opportunities and different types of ways that an individual interacts with the CCBHC, depending on whether or not their relationship with the CCBHC is mediated perhaps through a parole or probation officer, or whether or not that individual is seeking this help on their own. Same goes for specialty courts, and the specialty court also could be going through a probation officer as well.
Right.
So just segueing, does it require that probation and parole officers have a whole new set of skills? I mean, have they done this kind of thing before, sort of overseeing people's mental health care?
I'd say probation and parole officers face a humongous challenge, which is getting folks under their supervision into care. And so what this will do is it will enable probation and parole officers to have a deeper and wider bench of services that they can refer and monitor their clients with. You know, the numbers, Caddy, are something around a quarter, depending upon the jurisdiction, of folks that are incarcerated are there because they came back on a technical violation of probation or parole. And typically that technical violation of probation or parole is related to a failure of the community behavioral health system to respond to the needs of that individual because the resources weren't there. So
can you break that down, especially for the folks who are just healthcare writers? When you say a technical violation of parole, what kinds of...
Yes, ma'am. So when you are on probation or parole, you get a list of things that you can and cannot do. Okay. So, for example, you might be able to not have a positive drug test. You might not be allowed to hang out with certain people. You might have to go to your counseling session once a week. So those are called conditions of probation or parole. And about a quarter of the folks that are behind bars are there because they failed to meet one of those conditions, and their probation or parole officer reincarcerated them because they were on probation or parole, subject to fulfilling those conditions of release. One of the larger challenges is because the resources are thin, appointments are hard to get, they're hard to schedule, that what the Excellence Act is likely to do is, again, increase the breadth and depth of those resources. And in increasing the breadth and depth of those resources, it's likely to make the job of probation and parole officers much easier and hopefully lower the percentage of folks who are being back incarcerated because of a technical violation.
So do probation and parole officers, I mean, at this juncture, to what extent did they have these kind of skills to help someone who has a mental health issue sort of navigate the system? I mean, how does that work?
Well, it's really going to change or vary from jurisdiction to jurisdiction. I mean, there are lots of counties across the country that are trying really hard to get folks into the right kind of services that they need. The problem is that there aren't great provider networks out there for it. And on top of that, some of the problems is that these probation officers don't really know who to contract with or what the right kind of contracting system would look like. The CCBHCs now are going to allow a probation or parole officer to kind of hand that job over to people who might be better able to handle this situation, and then probation and parole can just ensure that these folks are maintaining the treatment regime that they're supposed to.
Right. And I mean, the part of the CCBHCs is that it's not only about shoring up the treatment services that are available, but there's also the care coordination requirements. There's targeted case management that needs to be provided. So it's also the in-between connection to services and working with the different parts of the social and healthcare systems to wrap services around that individual. It's not just the treatment itself, but also that bridge.
So are there places that at this juncture come closest to sort of meeting this ideal template? And where would those places be? Who's doing this work?
Nina?
There are pockets of excellence all over the country. I mean, there are organizations that have cobbled together the resources to be able to provide a comprehensive array of services, and have done a really nice job of integrating themselves into, developing relationships with public safety and criminal justice systems. But there isn't, one jurisdiction that we could point to. It's more the exception than the norm to be providing this comprehensive array of services.
So, but if you did name those pockets of excellence in case a reporter wanted to go there to sort of see and look and compare, where would those pockets be?
So one for me I would put at is Bexar County, Texas, and San Antonio, which has built, the contact person there is named Leon Davis. Or is it Leon's last name?
I'm not sure.
I'll find that's Leon, but that you can get it on the internet. They built a really effective integration system between mental health care and the criminal justice system, and they have lots of data, Caddy, on how much money they've saved the criminal justice system by building that continuum of care. So that would probably be the very first one on my list that would come.
Can you say the name of that county again?
It's Bexar. It's pronounced Bexar County in Texas. The county seat is San Antonio.
Thank you.
And so are there others?
That would be first on my list. Nina?
Specifically with criminal justice,
I'll give you more. You want me to give you some more?
You give more. It's a little political for me to be calling out.
That's right. You're a membership organization, right? So something else you might want to look at is in King County, Washington. They've developed what's known as the LEAD program, where they're doing pre-arrest diversion into the mental health system. They have some evidence-based data from a research study that just came out. That would be another one on my list. They're in the process of replicating that in Santa Fe County, New Mexico, and in Albany County, New York. So that would be another really good example. And the Wall Street Journal had an article 2 Tuesdays ago on LEAD and what's been happening in that jurisdiction. And the White House actually sponsored a conference on that on July 2nd, which is cited in the Wall Street Journal article, in which Coaches was one of the speakers at.
So the money ultimately for these, it's a combination of state and federal dollars, no?
Yes, that's correct. And actually, in the Texas example, that's all state and local dollars. There's no federal dollar that I know of in the Bexar County example. The King County example is actually almost all philanthropic dollars with some local dollars thrown in. I don't believe there are state or federal dollars in the King County example, which is why, Caddy, I'm using them, because these are examples that communities have built without a federal dollar. And so I would say what stood in the way of them being scaled is the lack of federal dollar in order to create the scaling. And so I think that's where this becomes really interesting. You can see some very innovative things that folks have done just with their own dollars in order to save their criminal justice dollar, which is, of course, then their own dollar as well.
Let me add one thing about your question about federal and state dollars. For CCBHCs, it like the Medicaid program in general, it's a federal-state partnership. So there is a local match component. But specifically for the demonstration program, there's an enhanced match for services provided through the demonstration program. So a jurisdiction that normally has a 50% match from the feds would have something somewhere in the 60s, for instance. So there's more money than normal coming from the federal government for the delivery of these services under the demonstration program, on top of the money that's available as part of the planning grants to help figure out this whole system. But also that planning grant funding can be used to provide training and technical assistance to your provider network to help them rise to the level of services they need to be for the CCBHC. There's like a readiness component to the planning grant.
Is there a sort of breakdown, a profile of mentally ill, incarcerated folks and what they were convicted of, what their crimes were?
It's local. I don't think there's any national data whatsoever that's been collected on that. And where a reporter would go to that would be to their local sheriff caddy, and they would ask their local sheriff, number one, how have they identified who had a mental illness going into their facility? Because that identification process varies greatly from community to community. And then the second question is, well, given that you've identified who is incarcerated because of a mental illness, can you, in a de-identified fashion, tell me what charges were brought against them? That's a very hard to aggregate that data nationally.
And I would say, don't underestimate how much sheriffs would love to have people be able to talk about this. Every place we go, they say, we've known we have a mental health crisis in our jail. What's taking everyone so long to realize it?
Graham, you have another question?
Sure, yeah, I'm going to jump in here. Edith Brady-Lunny again from the Pantograph. She said that Illinois, like other states, has seen a dwindling number of mental health beds at the hospital level. The use of crisis stabilization centers is urged for many communities. Is this part of the array of services outlined in this proposal?
Nina?
Yes, it is. Crisis services are available.
Fair enough.
Before you go on, what constitutes crisis services? What would that be? Sort of the dot and tittle of that.
So pretty much anything that you would send somebody to a hospital or that you would call 911 for, crisis services are often sufficient and able to step in rather than having somebody actually go to a hospital. I do want to correct one thing. It's not for residential services. There has to be care coordination between the CCBHC and residential programs, but there aren't crisis bed programs under CCBHCs. But there is 24/7 mobile crisis teams. So on an outpatient basis, people can get the supportive services.
Is that problematic that there are no crisis beds?
Well, the legislation requires that it not be used for residential services. So it's not preventing states from having crisis beds. In fact, some states do have crisis beds as part of their array of services. It's just this particular funding stream, this demonstration program, is about the outpatient community-based services.
Now, separately, just for reporters' interest, Patty, that's not really related to this, on Monday, CMS released new guidelines for states to receive federal funding for residential services for individuals with substance use disorder. So up until now, those funds were not available for residential services, and the feds changed that rule set on Monday.
Dan, were you going to say something a minute ago?
Yeah, I was just going to say that the crisis services that we're talking about really fall into that first intercept point, just so that I can help frame that a little bit. What happens when somebody calls 911? Do they send the police, or do they send one of these intervention teams that can come in and de-escalate and help meet the behavioral health needs of the individual?
How widespread across the country are those crisis teams? I mean, I know we talked about that at the conference, but where are they? And do they mostly not exist, or do exist? What?
Well, I don't know if I could say percentage-wise what exists and what doesn't. The crisis intervention teams have existed since the 80s. They started in Memphis, Tennessee, and they really are in major jurisdictions all across the country. This is one of the things that we're seeing folks are really investing in at the correctional level on the police side in order to try and de-escalate. They exist in California, they exist in New York City, and they're really, obviously, this is the first intercept points, one of the first ways that a situation can be de-escalated before folks get into the criminal justice system.
Right, and if there are any reporters from New York State on the line or in the fellows, the New York State Legislature in its last session actually voted significant dollars to expand CIT training in New York State for law enforcement all through the state.
I'm sorry.
Bexar County does a great job of this CIT training as well.
I have one last question before I ask y'all to sort of wrap up and throw out story ideas and ones that can be replicated in anywhere a reporter is. So can you sort of paint a step-by-step of who one of these convicted people would be and the process, walk through under this new model hypothetically where they would go, how they would be treated. Does someone go to jail for a moment and then get out, and how will it work?
I think, Hattie, that's a really good example. So let's talk now about how the assembly line goes right now and how it might go. Okay. So I have someone who's dealing with a mental illness issue, who is let's use New York example, who's directing traffic on 125th Street, and they're not a law enforcement officer. Okay. So currently, what's going to happen with that individual is the police are going to come. They're going to tell that person that they're not authorized to direct traffic on 125th Street. They're going to handcuff them. They're going to take them to jail. They're going to be arraigned. Most likely, they have prior convictions, and they fail to appear for other court dates. They will then be remanded to a jail. It will take 3 or 4 days before that person is diagnosed and put on medication in that jail. They will then be sentenced to time served and sent back out into the community with no support. That's how our assembly line runs right now.
And which also the time until the disposition is over for somebody with mental illness is 2 times as long than someone who doesn't have a mental illness.
Right. Right. We talked about that in New York. So now let's do this in a brave new world of an Excellence Act jurisdiction. Okay. So hopefully what's going to happen is I'm not just going to send a law enforcement officer to 125th Street. I'm going to send a social worker. That I'm going to have used Medicaid funding to develop an outpatient crisis drop-in center, let's call it that for the sake of simplicity. Instead of taking that individual to the jail, I'm going to take them to that outpatient crisis diversion center. There, they're going to be met by a behavioral health team. They're going to figure out what the needs of that individual are. They're then going to go ahead and meet that needs of that individual so they hopefully never even end up in the criminal justice system. I think that's a really simple example of how breadth and depth of funding through the Excellence Act is likely to significantly change what the current course of is people dealing with mental illness in the justice system.
And let's say that first intercept point doesn't work. The person, say they were then taken to jail, they could go into a mental health court or some other way of getting somebody out of the criminal justice system instead of putting them in. Or say post-arraignment, then they are released subject to treatment. That treatment could now be available through a CCDHC. So this is why the intercept model is really helpful for this process, because you can see if we aren't able to catch this person and actually meet their needs at the beginning, there are different places all along the way where this individual could be diverted out of the criminal justice system and into more appropriate community treatment. And the CCDHC now offers that opportunity.
So story ideas, Patty, we have about 5 minutes left. Do you want to do story ideas?
Yeah, story ideas. And before you go, so are there people who will be difficult to treat, even in this idealized world?
Yes, ma'am. Absolutely. Okay. So it may be, going back to that guy on 125th Street, that he proceeds to take a swing at the social worker or the cop who's trying to stop him from doing his job of directing traffic. Okay. That's not going to be so simple as what I described. That individual is going to end up being taken into court. They now have a felony charge against them of battery against a law enforcement officer. And again, the question is going to be at arraignment, going back to what Dan was saying. Right now, for a felony individual like that, we don't have a lot of other options other than, again, they're going to sit till their time served. If it's a first offense, they'll get released with time served. If it's not, they may get convicted of something. The resources of breadth and depth make it possible to understand that that swing, that felony, was a result of a failure of a mental health system, and that in and of itself, while it may meet the texture of being a criminal act, it's not really someone who's a criminal who we need to lock up in a state prison. So I think, yes, there will be lots of difficult folks to treat, and again, breadth and depth is what will address that.
Okay.
Story ideas. Right?
Yes, whip around. Thank you.
Story ideas. So what I would say is your locality in a jurisdiction that's applying for the Excellence Act? How is it likely to add to breadth and depth of the current situation? Again, Nina's given you some local resources for reporters to talk to about that. Talk to your state folks. As she said, there's 3 state actors involved in this, and Nina can direct you to them in each of your states about why they decided or didn't decide to apply for the Excellence Act, how they see it impacting the criminal justice system. On the first slide, Nina showed you the public safety organizations that are part and process of building this. You'll have spokespeople in all of those folks who are happy to talk to you, both at the local and at federal level, about how the Excellence Act can change the course of folks with mental health in the criminal justice system. So that would be my story ideas going by first.
Okay.
And I would position this inside of the grand arc of history or something, where this connects in with deinstitutionalization, where people were just thrown out of institutions onto the street. This led to what I would say is why we see so many people being institutionalized inside of jails and prisons, because those needs haven't been met, and because the community treatment that was promised during deinstitutionalization just simply did not exist. And now we're finally getting to the point where the institutionalization of mental health problems was seen as a problem. Now we're beginning to understand how the institutionalization inside of jails and prisons is a huge problem, and CCBHTs are really finally going to offer a lot of the resources and opportunities to meet the needs of folks in the community instead of the needs of.
And then if you think about it at the really micro level, so Steve was talking about it at the state level, if you think about it at the local organizational level, if there are mental health or addiction treatment organizations in your community that you wanted to talk to and even ask the simple question of what could be done differently if you were reimbursed for the full cost of your services rather than just getting a small percentage of your cost, but what if you were fully funded, what could you do? How many more people could you serve? It's another angle.
Okay, thank you, you guys. Nina, would you send me your slides?
Yeah, you bet.
I'll include that in the summary and the link to the fellows who were not able to get on it. Thank you, you guys. This was great. We fully expect some coverage to come out of it. And Nina, you should expect fellows to be in contact with you,
Great.
Steve, and
Wonderful.
Dan. They will do that. Thank you so much, y'all. Enjoy the rest of your day.
Take care.
Okay.
Bye-bye.
All righty. Bye-bye.